ஹாய், இன்றைக்கி நாம் JIP DYK ப்ரோக்ராமில் நாம் பார்க்குற ஒரு டாபிக் என்னென்னா how to differentiate anemia based on MCV. So last sessionல then I told when MCV is decreased what would be the differential diagnosis. Just I want you to recollect or rekindle your memories. When you have decreased MCV, mean corpuscular volume, lesser than 80 femtoliter, 4 differential diagnoses we have seen. That mnemonic word is ILTS. 1 iron deficiency anemia, second one L for lead poisoning, T for thalassemia and S for sideroblastic anemia. Likewise, now we are going to see when MCV gets increased, I mean more than 100 femtoliter, what are the differential diagnoses? So here one simple mnemonic word is, so we study HLA-B27, allele, locus, genes. So you remember something like that, HLA-B, okay. H, remember hemolysis. Same H denotes hypothyroidism. And L for liver disease. B for B12 deficiency. When you say B12 deficiency, then another twin brother, folic acid deficiency also you have to take it. So HLA-B, then one more important is MA, myelodysplastic syndrome and aplastic anemia. So the code word would be HLA-B, MA. So or HLA-B, MA also you can remember, BMA, okay. So H for hypothyroidism and hemolysis, and L for liver disease, A for alcoholism, and B for B12 and folic acid deficiency, and MA I told, M for myelodysplastic syndrome and aplastic anemia. Okay. So when somebody presents with anemia, as I told you earlier, please give much importance to MCV. Look for MCV. If MCV is more than 100 femtoliter, these differential diagnosis should be brought into your mind. So among these, all these causes, the most important cause would be definitely B12 deficiency or folic acid deficiency. So when MCV is more than 100 femtoliter, this is called macrocytic anemia. So there is one another term is there, that is called megaloblastic anemia. What is the difference between megaloblast or macrocyte? So macrocytes are the one what we see in the blood generally, peripheral smear, the size will be larger, that is called macrocyte. But megaloblast is the one, the same macrocyte that will be seen in bone marrow. In the bone marrow examination, they will see this megaloblast. Then only we say that it is a megaloblastic anemia. Sometimes megaloblast may escape bone marrow and enters into the circulation. Megaloblast may be seen in the peripheral smear. Otherwise, generally, whatever red blood cells that are more than 100 femtoliter, we should call it as macrocytes. Among macrocytes, I mean that macrocytic anemia, you have two differential diagnoses. One is megaloblastic anemia and another one is non-megaloblastic anemia. Among this megaloblastic anemia only, you have all these causes, what I told you, HLA-B including B12 deficiency. Sometimes drugs also may cause macrocytes like chemotherapeutic drugs, okay. Sometimes have anticonvulsant drugs. So this all under megaloblastic anemia. So macrocytic anemia, one important cause, megaloblastic anemia, because all these causes will have megaloblast in the bone marrow. That's why invariably we are using, instead of macrocytic anemia, we always say megaloblastic anemia. There is one condition where you will have macrocytes in the peripheral smear, but there won't be in megaloblast in the bone marrow. Where it is commonly seen, when you have abundant amount of reticulocytes. For example, when you have reticulocytes more and more in the blood, the most important reason would be hemolysis. When you have hemolysis, for example, due to whatever acute hemolysis, secondary to malaria or babesiosis or artificial prosthetic valve or hereditary like congenital spherocytosis, hereditary spherocytosis, hereditary elliptocytosis or G6PD defect, whatever reason, when hemolysis occurs, okay, there will be profound anemia. So what happen, our body will sense that anemia, then that will put much pressure on the bone marrow to release more and more RBC to compensate anemia that is seen in the peripheral blood. So bone marrow now it is under pressure, so it instead of releasing the mature RBC, since there is no time, so bone marrow releases all kind of pre-RBC stages, a pre-RBC stage of some cells. That pre-RBC cells are otherwise called reticulocytes. Because of more demand that is elicited by our body to compensate ongoing hemolysis, there is more premature RBCs are released from the bone marrow, that is called reticulocyte. So these reticulocytes larger in size as compared to RBC, so it will give rise to macrocytes. So it will be depicted in increased MCV in automated cell counter. So when you have increased MCV, one important cause megaloblastic anemia. What I told you, everything, that B12 deficiency, L for liver disease and hypothyroidism, chemotherapeutic drugs and everything. Then another important cause, non-megaloblastic anemia, is hemolysis. Because of hemolysis, reticulocytes are abundant in your peripheral blood. So this reticulocyte will give rise to picture of increased MCV. So these are the causes of increased MCV. So just I want to highlight few points about B12 deficiency. Why B12 deficiency? You are able to witness more macrocytes. So to be honest, instead of you witness pure macrocyte, in B12 deficiency you will have macroovulocytes, little bit oval in shape. Instead of maintaining normal size, why you have macrocytes in B12 deficiency? See, normally in any cells, you are aware that there is nucleus and another one is cytoplasm. In the nucleus you will have DNA. This DNA synthesis warrants B12 and folic acid. When you don't have adequate amount of B12 or folic acid, secondary to malnutrition or intrinsic factor deficiency or some kind of some intestinal disease or gastrectomy, whatever reasons, sometimes pernicious anemia, okay, or either due to liver disease you may have B12 and folic acid deficiency. Whatever reason, when you have B12 and folic acid deficiency, this DNA synthesis of RBC is impaired. When DNA synthesis is impaired, what happened? Nucleus synthesis is impaired. So in the RBC, nucleus synthesis is impaired. But what happened in cytoplasm? You will have RNA and protein synthesis in cytoplasm. So this RNA and cytoplasm doesn't require B12 and folic acid. So in RBC, during the time of RBC maturation, the nuclear division or nuclear synthesis will be halted or will be going down because of B12 or folic acid deficiency. On the other hand, maturation of cytoplasm may be uninhibited. So what happened? Your nuclear division is halted. Because of that, the cellular division or mitosis of the cells will be inhibited. So there won't be any cell division, but instead of that, cytoplasm grows as usual normally, but nucleus doesn't grow. So there won't be any cell division, and because of normal cytoplasmic maturation, your RBC will be enlarged, but there won't be any further division. So you develop macroovulocytes. This is the reason for macroovulocytes or macrocytes in the peripheral blood in B12 deficiency. Apart from that, in B12 deficiency, you have one important finding. There will be ineffective erythropoiesis and there will be intramedullary hemolysis. What is ineffective erythropoiesis and intramedullary hemolysis? Because of B12 and folic acid deficiency, there won't be no maturation of RBC in bone marrow. So what happened? There won't be any production of RBC adequately. This is called ineffective erythropoiesis. Then apart from that, what happens in B12 deficiency? Within the bone marrow itself, whatever RBC, whatever meager amount of RBCs are produced that are lysed within the bone marrow itself, then what happens? You have hemolysis within the bone marrow. Because of this hemolysis, you will have increased unconjugated bilirubin in the blood. So when you see B12 deficiency, not only there would be increased MCV in the RBC indices, if you look at if you do liver function test, there will be increased unconjugated bilirubin, highlighting the evidence of hemolysis. Then apart from that, in B12 deficiency, they will have thrombocytopenia and they will have leukopenia. I could say one of the important causes of pancytopenia in our Indian entity is nothing but B12 deficiency. Before you think rare causes of pancytopenia in India, I think that I could say B12 deficiency should be strongly considered as most important contender for pancytopenia. Then apart from that, in peripheral smear, as I told you that myelodysplastic syndrome and aplastic anemia also can produce macrocyte, but when you look at B12 deficiency, the size of the macrocyte would be much larger. I mean, I could say instead of 100 femtoliter, that is a maximum limit of your RBC size. Here you will have 115, 120 femtoliter. Whereas in aplastic anemia and myelodysplastic anemia, you will have increased MCV. There will be marginal elevation of MCV. But in myelodysplastic syndrome, in the peripheral smear, they will have give some clues. For example, RBC will be there. But what will happen? Nucleated RBC will be there, nuclear atypia will be there. If you look at the neutrophils in myelodysplastic syndrome, the neutrophil instead of 3 to 5 lobes, there will be lesser than 3 lobes will be there. And if you look at the platelet, there will be varying size of the platelet, anisocytosis will be there. So these are some evidence for myelodysplastic syndrome induced macrocyte. But when you look at aplastic anemia, so all three cell series will be depleted. So they will have pancytopenia and there will be mild elevation of RBC. I mean simple macrocytes will be there. But in B12 deficiency, as I told you earlier, because of nuclear arrest, because of poor maturation of nucleus, there will be nuclear remnant will be seen in the RBC that will be seen as Hubble-Jolly bodies in B12 deficiency in peripheral smear. Apart from that, in the neutrophils, normal lobes in the neutrophil is single neutrophil is 3 to 5. Instead of 5 lobes, there will be more than 5 lobes will be there in neutrophils. That is called a hypersegmented neutrophil. So hypersegmented neutrophil, Hubble-Jolly bodies, more macrocytes. In the bone marrow, you will have megaloblast, and when you do biochemical investigation, there will be decreased B12 and decreased folic acid will be seen. Then apart from that, there will be some indirect evidence for B12 deficiency and folic acid deficiency. In B12 and folic acid deficiency, the simple biochemical difference would be in B12 deficiency, both homocysteine and methylmalonic acid MMA will be elevated. In folic acid deficiency, only homocysteine will be elevated. I think that this would be little bit broad elaboration, but for all clinical purpose, when you have increased MCV, always think of HLA-B-MA. H stands for hemolysis and another H stands for hypothyroidism, and L stands for liver disease, A stands for alcoholism, and B stands for B12 and twin brother and folic acid deficiency, M for myelodysplastic syndrome, and another A for aplastic anemia. Then hypothyroidism, how it contributes megaloblastic anemia, they are telling their mechanism is poorly understood, but they say because of thyroid hormone deficiency, it directly impacts in the RBC maturation, resulting in macrocytes. So these are some of the causes for increased MCV. But in our day-to-day practice, what we commonly see, the most important is B12 deficiency and folic acid deficiency, and hemolysis. Don't forget that hemolysis, you will have increased MCV. Immediately do reticulocyte count. If reticulocyte count is more than 3%, think of hemolysis. Then very less commonly we see liver disease and alcoholism and of course hypothyroidism and so on. Thank you.